Hi, my name is Diane, and I'm a mental health nurse. I'm board certified in psychiatric nursing, and I'm here to do part 3 of mental health and older adults, normal changes versus dementia. Now, the reason why I think that this is an important thing to go over is because of the bias and stigma that a lot of healthcare providers, or maybe understandably, feel when someone comes into their facility that cognitive decline and dementia is expected, and so I wanted to go over a little bit of information on what normal memory changes are like just normally in a population and dementia, and some things that we can do when we have that understanding to optimize people's life, and that's what we're here to do. So the purpose of this section, which is part 3 of 6, is the goal is to provide education and understanding of normal physical and psychological changes older people experience without having a mental health diagnosis, and the learner will recognize common stereotypes and myths about normal aging to help provide better care for their patients. They'll recognize that elderly of different generations have different societal and cultural coding. So the expectations of the healthcare provider should be different and their care should be adapted, and that the learner will also identify behaviors that promote healthy aging. And really this applies to anyone in assisted living, but I just wanted to make sure we were specific to the cognitive changes of aging. And of course, anything that we talk about with structure, routine, optimizing care always applies to everyone in placement. So the objectives of this section is to provide information and instruction on the psychological and physical aspects of aging and their impacts on mental health, identify behavioral and lifestyle choices that promote mental health and aging, and understand chronological versus biological age and how it impacts care. Our first slide would be chronological versus biological age. For example, someone who's 65 who has made good lifestyle choices throughout their life, genetically was born in good health, lived in a pollution-free environment, didn't work coal mines, really had a healthy upbringing. So many factors go into that 65-year-old. A 65-year-old who was born perhaps without good health care, suffered serious trauma and addiction issues, maybe worked a very hard labor job, ate a very poor diet, had diabetes untreated most of their life, would present to you differently. So all 65-year-olds are not the same. And basically the chronological age is a measurement of the time they lived. 65 is 65. But biological age difference. And that's what we just talked about. Biological age of anybody has to do with a lot of factors: behavioral, biochemical, genetic, metabolic, evolutionary. So these things are given. Some people, like certain people, are predisposed to having different illnesses. Tay-Sachs disease are in certain populations. Certain populations have higher incidences of higher blood pressure and diabetes. So that would be the genetic. Behavioral, of course, are lifestyle choices, whether you were a heavy smoker, heavy drinker, didn't manage your stress well. Metabolic, of course, diabetes, any type of metabolic issue. Evolutionary, your genes. Were you born healthy? Did you come from really robust people who were very resilient, genetically strong? And biochemical, what have you been exposed to? Heavy doses of pollution, just all kinds of things. So some of these variables are static and fixed, and some are kind of malleable and can be changed, particularly the behavioral, the biochemical, the amount of medications, the drug addictions, the lifestyle choices. Genetic, evolutionary, not so much. But even genetics has been having some extraordinary changes. So something to think about. So I just really wanted to think about chronological versus biological age. A 98-year-old individual who is on the same facility as a 71-year-old, totally vast and different experiences. A 98-year-old may bring the trauma of living through World War I, the Korean War, not World War I, World War II, the Korean War, Vietnam, the Depression. They would come culturally and societally coded to be different. A 71-year-old would have different experiences, although they may have the same diagnosis, dementia, maybe on the same unit, but they would present as a totally different cohort in time. It would be almost as though, even though I could read about living in the castle days, I can't really access that reality. I don't know what it's like other than in pictures or in movies. I've never lived in the dark stone walls of a castle or had to use a chamber pot or scurried around dark, dank halls in the dark with a candle or slept on a straw mat. So I don't know. I really don't know what that's like. I can only read it, but I don't have any like first muscle memory of that event. And that would be the same. That's a very extreme example, but people that have been reared up in technology have no idea what it's like. They could never know what it's like never to have a cell phone, never really to have anything like that. So we're coming from totally different perspectives, but even though we could never really know, we can know that we have a different perspective and try to incorporate and understand somebody else's. So fixed versus variable biological age factors, we went over this briefly. Genetic and evolutionary, they're fairly fixed and static, although great advances in genetics, that might not always be the case, but for now, it's pretty much true that those genetic variables are pretty static. Other biological factors that can be influenced, minimizing exposure to environmental toxins, reducing stress, quitting smoking, and fidelity to the right treatment. So I always like to believe right patient, right treatment, right time. The best time to manage diabetes is when you're first diagnosed, not after 20 years of bad management. You're going to have better outcomes if you get the right diagnosis at the right time, the right treatment. And with that comes fidelity. And fidelity means honoring that treatment. So somebody who pretty much managed their blood sugar faithfully and well for 20 years versus someone who said, oh, I'll just take extra insulin after I eat this cake. They may have different health outcomes. Something to think about, it's never too late to improve the health of your patient with lifestyle changes. All of our healthcare providers should be encouraged to always invite and encourage your patient to engage in any exercise program that promotes physical health, encourage them to get up and about moving. Now, this is important just for regular cognition. Regular health is also extremely important for all mental health diagnoses, including dementia, increasing socialization to promote mental health. That's why there are activities directors. I mean, it may be cumbersome and hard to get the cranky patient down to the community room. I mean, ideally post-COVID. To participate in the sing-along, and they may pitch a fit and moan and say it's stupid, but all attempts should always be made because we are social creatures. Human beings are social creatures. We thrive and crave human interaction, and so that is something that remains stable throughout a lifetime. We need that. They need that. Everybody needs that. Optimal nutrition is just a fantastic way of promoting a lifestyle change and giving nutrient-dense food that will help all body functions. And the other thing the healthcare provider can do is to really assess for changes and to know the patient's baseline. And so if you know that Mrs. Lilly is usually very with it, and she seems acutely confused, to not say, oh, people have days like that, to really elevate that to your supervisor so that appropriate interventions can be made. So I just wanted to talk about the cohort effect. By definition, a cohort is a group of people with a common statistical characteristic. And so this is a bias that I wanted to at least address because everyone, you need to group people into diagnoses because that provides standardization of treatment, interventions, analysis, assessment. So to get a diagnosis, hopefully, is the entry point to the right care, the right diagnosis, the right care, the right fidelity to treatment, the right outcomes. We always are very cautious to diagnose people. We don't want to label them, but labels can be very effective if they help get the right payment, whatever. So sometimes there's an upside to having a diagnosis because it gets you the right care, the payment, the right treatment, and hopefully the right outcome. But on the other hand, when someone has a diagnosis, people have a stigma or a bias, and they think, well, manic depressive. This person's upset because, they're bipolar. When they might have a legitimate reason to be upset, they might have a legitimate reason to be upset with you. So you really have to be able to be super duper professional and understand your own bias and stigma. And also to understand the cohort, which is really from which they come. It could be a cultural cohort, it could be an age cohort, it could be a regional cohort. You really have to understand that people come to you with a certain statistical in a certain statistical grouping to which you may not know, and your care may be impeded by that. And the one that I think is the most significant or need to know is grouping people over a certain age as all being the same, when that age could really vastly, it could be a difference of 30 years. And also to pull that understanding through the years. Hopefully, if you're young, you're going to remain in healthcare and provide care for years and years and years. So what you knew about elderly people 20 years ago, 10 years ago, some of that knowledge can be pulled through to the elderly person of 10 years on or 20 years in the future, but not all of it. So you always have to understand that these cohorts and this statistical common groupings in time will change as time changes. So what you knew 20 years ago may not apply to the older person of today who is more tech savvy, who is more traveled, more educated, more well-read. And so that's something that I would like for you guys to remember. We talked about the cohort. So understanding cognition and aging and normal cognitive decline, I just thought that this was a little important because I think one of the common stigmas is that after a certain age, everybody's a little confused. That's just the way it is. And so I think that maybe in some regards there is a little bit of truth to that, but just a tiny little bit. But when we look at what is normal, we can adapt our care and provide optimal care and thus have optimal outcomes when we understand normal memory and normal cognitive decline. So confusion isn't really necessarily a part of getting older. Now, delayed or a slowing down of cognitive processing times, yes, but not confusion. So to understand the difference, that's something that you should think about. So I guess for us to do that, we should do a little quickie on understanding memory types and in everybody, there are several types of memories, and understanding how they work and what they do and how they change as someone ages will help the healthcare worker understand the patient's behaviors and cognition and how to interact with that individual to optimize the goal or the end result. So basically everybody, I believe, is basically a compilation of their rituals, routines, memories, experience. That's the sum of that person. So any type of memory loss of any kind is a great loss. It's not a little loss, it's a great loss. So what memory is the ability to register and retain knowledge and recall it. And some forms of memory remain stable over time, and some forms decline. Now that's really important for you guys to remember, because that would make you not recognize some dementia symptoms if for some reason you go in and they seem to really be with it. But remember, some memory remains stable over time and some doesn't. So it depends on what you're asking and what you're talking. And so in order to provide great care, you should be a skilled interviewer in a way of speaking. I know I used to be a board certified psychiatric nurse. I mean, I am now, but I used to work on the ridge with elderly people up in the mountains. Their kids would stop and, chat for 10 minutes or whatever. But they never really stayed longer. They might have stopped daily, but they just stopped. Hey, Mom, did you take your pills? Did you eat your dinner? Blah, blah, blah. And they would leave. And when I would first go to see these individuals when I was a very young nurse, well, they seemed as clear as a bell. And I'd be talking to them for about 15 minutes and 20 minutes. And then in 20 minutes, the entire conversation would start again. And I always had this barometer. I would stay at least an hour in an initial visit to give it a chance for the conversation to start again. Some people were so rote in their structure and routines, and they were able to survive in that routine and answer these questions. But if you would go off script and say, what did you have for breakfast? They're like, I don't know. And that was always pretty much a telltale clue. It's easy to say, did you have breakfast? Yes. What did you have for breakfast? That ability to recall that is not so easy. So to learn how to ask the right questions is important. So let's talk about short-term memory. Short-term memory is kind of like a mental scratch pad. You roll down the window, you say, hey, what are the directions to, I don't know, you're going to IKEA. And the person says, make a left, make another left, make a right and a left. You're like, left, right, yeah. Gotcha. And you're good until there's a roadblock or you get a phone call that kind of diverts your emotions. I don't know, your kid flunked a test. And then you're like, what did he say? I don't remember. I think it was a right or left, I'm not sure. So as long as you're kind of there in the moment, you're remembering it and you kind of retain it. But if you would ask somebody like 10 minutes later, a telephone number, or an hour later, or 3 days later, hey, what was that telephone number? Very few people would be able to recall that. So it's a mental scratch pad. And there's two parts to it. It's just like, hey, I'm going to give you this telephone number. Will you remember it? Probably for 10 minutes or so. But there's another part. Could you reverse it? And sometimes people, when they're first having memory problems, they're able to maybe parrot off what you've told them. They're not able to manipulate any information short term, even in their scratch pad. So semantic involves retaining knowledge, facts, and word meanings, and it usually doesn't decline with age. Now, we're not talking dementia here. We're talking about normal cognitive decline. So working memory, the scratch pad, that kind of thing, that declines normally. Semantic memory, knowledge, that's why people really remember things very vividly from their past, and they can just describe their experiences in the war very compelling and in great detail. And procedural memory, like a motor skill or procedure that they've done year after year after year. These really don't decline in normal cognition. So somebody that has stayed in their house for a very long time and done very well and walked out to the mailbox and made their coffee and they stayed in their same structure and routine, they may not, their cognitive decline, if it's starting, they're able to function very well in that environment. If you would take them to the hospital or you would take them somewhere else, they might not be able to function as well, because it's the routine and structure that we'll bring up later in this little course that really helps optimize their functioning. So long-term or episodic, and that has to do with the acquisition, the storage, and the retrieval of information from a particular place and time. So your first birthday, when JFK was killed, 9/11, even what you had for breakfast. So breakfast is kind of mundane. They may not remember that. But if you pair these things, the reason why people remember what they were doing at 9/11 or JFK or something, what they were, how they felt when they got married or whatever, is because it's paired. It's called a light bulb or flash bulb moment when it's paired with real significant emotion, and it kind of anchors it in, and it makes it more easy to retrieve. That's why they always say celebrate your memories. If you want to anchor them in, if you want to remember something, you kind of pair it with a physiological response, an emotion, a smell, and then you're more likely to be able to retrieve that. Okay, so we have, why is it important to understand normal changes in cognition? Well, it's important to understand normal changes in cognition to provide good care, and also to recognize what isn't normal changes in cognition. So, and when it's pathological. So, the knowledgeable healthcare provider would do the following: dismiss the bias and stigma that all older people are confused. So we know, based on what we just learned about memory, that there are some types of memory that slow down, aren't as easy to do for older people, but for the most part, most memories remain fairly stable, but maybe slower and more difficult to access. So acute confusion or total disorganization is not a part of getting older. And when someone does start to experience a decline, then they should not be dismissed as, oh, that's just part of getting older, like when they're 80 or 90 or 70 or 60. I would also like the healthcare provider to incorporate their understanding of memory and realize that the organization of the home environment routine has been disrupted when that occurs. So how does that apply in long-term care? When you disrupt the schedule, when things change. Sometimes things have to change. But when somebody really reads their paper, goes to the toilet, eats their breakfast in their slippers, goes down to group, when all of a sudden that changes, then you should incorporate and expect that possibly some confusion, maybe some irritation, some irritability, some anxiety may result by the routine not being followed. So when you understand normal and abnormal, then you can understand how you are part of the healing environment and how you changing your behaviors and your structure can impact others. So when we're talking about normal changes and then dementia, what dementia is, and that's a group of symptoms that affect memory, cognition, and functioning. There's tons of types of dementia, the most common being Alzheimer's. But there are vascular alcoholic, Parkinsonian, like the Parkinson's dementia. Um, there are frontal temporal lobe dementia. There's just some. There's different kinds. They have different symptoms, but for the most part, they can affect memory, normal thinking, communicating, reasoning ability. And I always like to say, they always said this about autistic people, that once you meet one autistic person, you've met one autistic person. Same for dementia. Once you meet one dementia patient, you've met one. Everyone throughout their entire life is a unique and sovereign human being. They have their own likes and dislikes. They have their own way of interacting with the world. So, same for dementia patients. Some of the symptoms are similar. The unique individual is different. So, with dementia diagnoses, they can have cognitive and sensory changes and psychological changes. So, and there's a list of them. Memory loss is just one of them. Word finding challenges, difficulty with organization, confusion, disorientation. Sometimes it can impact fine and gross motor coordination. It can give them a metallic taste in their mouth, a decreased sense of smell, and reduced visual challenges. Psychological changes in dementia, changes in personality and behavior, depression, anxiety, hallucinations, mood swings, agitation, and apathy. Personality is one of those things that really doesn't decline or change over time. And so when there are changes in personality and behavior, that's particularly challenging for people, and often a sign of cognitive, like there's something wrong. So when we're talking about normal changes and dementia changes and the structure of routine for all patients, providing a structure and routine offers a sense of safety and security that's important for anxiety, depression, schizophrenia, all the things we talked about before, dementia, and elderly people that could be in your care. So when you have a structured routine, it's easier for memory storage, it's easier for memory retrieval. Think about how rotely you do things, and which you don't even think about. Making your coffee in the morning, you can multitask galore when you have a routine. It's like that for all of us. Like, we have muscle memory that we do things and we have certain routines. I know for myself, I drink coffee in the morning, I sit quietly, I kind of daydream and plan my day. And for some reason, if I have to get up very, very early, I get a little bit of anxiety about that because I'm like, I can't drink my coffee, I can't sit with my dog, blah, blah, blah. So, and it doesn't change. It's the same for everyone. So, structure and routine when possible. There are some people who are very, very ritualized with their routine, which is problematic. But for the most part, it provides safety and security for people. It structures their day. It helps them organize their thoughts. So be very careful about changing any kind of structure and routine in your day. And it also helps sleep and toileting schedules. When people have a routine, it really helps things. And when you help the way you do one thing kind of impacts the way you do everything. When you have the structure and routine of the unit and that individual day goes better, your day goes better, the surrounding staff goes better, everything is better. So routine and structure can really help streamline everything in the facility and with all people that work there and live there. So optimizing the environment, what can we do for older individuals? Again, I'm talking just about older individuals in this section, but it can apply to anyone. First, you have specific knowledge when you learn it, but you can also generalize that to all populations. Hopefully that people don't stay married to the idea that one concept must stay with this. That's a bias and a stigma. That when you learn a concept or something to apply to your personal practice, that you can use it specifically for that. And you will retain that knowledge and say, oh, this is how a dementia person would react to this, but also to broaden your perspective and think, hey, I'm going to generalize my knowledge. And how would an IDD person respond to this? How could I use this knowledge to help this anxious person or this depressed person? So, really, to recognize that with cognition, with elderly people's cognition, there's a slowing down of some processes, but not confusion, and some things remain stable. However, it is a new environment, new and complex things would require the person to be able to be mindful, to be a healing environment for their patient, to speak slowly and clearly with maybe single-step commands instead of saying, hey, after you take your pills, we're going to take a shower, then I'm going to take you down there, and then I'm going to get while you're walking out of the room. Because you already understand that there are things as you grow older, your hearing goes, your vision goes, there are some things that slow down. So you accommodate and you do everything to decrease the anxiety of face the patient, let them see your mouth, speak slowly, but not real loudly and slowly, but in a very respectful way. Give them a chance to think and answer before you answer for them. To understand that all individuals have patterns and rituals is important as well. Some final thoughts. I just really think that it's important for all healthcare providers to understand normal aging as opposed to dementia and what the difference in memory types are so they can accommodate and adapt their practice to that. They should always know their patient's baseline. Someone who was not confused 2 weeks ago and fully demented probably should not be today. Like if their highest level of functioning 2 weeks ago was they were out driving their car, participating in groups, and now they're not remembering who their daughter is, that definitely is probably a medical emergency. Now, to be aware, to understand what the patient's diagnosis, to understand their normal patterns means that you would understand when to report changes. And when your unit is structured and organized, then and you follow that structure, that allows you to assess people more clearly. And that's all that I have to understand that, first of all people, despite their diagnoses, are individuals, that there are normal changes to be expected and accommodated, that all patients benefit from structure, that not all elderly people's confusion can be dementia related, and that a lot of the optimal outcomes depends on the healthcare's understanding, interpretation, and implementation of this information. And that's all I have. Following this is a short 10-question quiz to help cement and anchor in your understanding, and I'll see you with the next one.